4 years ago, sepsis was just another diagnosis made by many different docs, using many different criteria and treated many different ways. Then some core people in the ICU decided that we really needed to make the effort to improve the day-to-day sepsis care at Lakeland Regional Medical Center.
I consider sepsis in patients who are newly intubated, who develop hypotension. Once the lactic acids have been resulted, if the lactic acids are greater than 4.0, that launches the initiation of early goal-directed therapy. Another item we look at is the use of vasopressors. If after a 20 ml per kg bolus the patient still remain hypotensive, we initiate vasopressors.
If I see a patient that triggers me to think that they're possibly septic, I would go and grab a sepsis screening form, go over the A, B, C, D in the sepsis screening, and then show it to the physician, possibly send off, see if he can send off a lactic acid. When we get a patient that we think is possibly septic, we want to be sure to get blood and urine cultures, sputum cultures, any kind of wound cultures, try and administer antibiotics within 1 hour, and then prep the doc to see about getting in a central line, have the supplies ready at bedside so that we can get in as soon as possible. Some of the other things that may have made this take off is some of the nurses have maybe received some gift cards for dinner or other things. And also, we're really here just to do what's best for the patient and do the right thing. We want to keep up with the most recent treatments. And so really, it all boils down to being what's best for the patient.
But another thing I think is really important with getting doctors to change their practice is you need to get feedback to them about what they're doing right and what they're doing wrong quickly. It doesn't really help much to send something out 6 months later saying, you know, you should have given the antibiotics faster. So one little thing that's happened is we tend to get email feedback that when we have good cases or bad cases, and usually those come within a few days to a week of the actual case. And I think that's been pretty helpful.
Well, I think that we've all become much more aware of the need to put central lines in sooner and initiate large fluid resuscitation sooner than we ever had previously.
The emails have had a very positive effect on the physicians and have allowed us to think more about treating sepsis and being more rapid in that treatment. Some cases we've had very constructive emails. In other cases we've had some patients fabulous outcomes. So when we go in to see and treat our patients, we're constantly thinking, and the reminders from the emails have been very helpful.
Whenever we feel like we do have a candidate that's a sepsis candidate, we have a protocol that we use that's been pretty spelled out with separate categories. The triggers are all there. You meet A, B, C, and D, and these are things that prompt the nurse to go get in touch with the physician and let them know that we probably need to send off a lactate and think about putting a central line in the patient.
Well, it was very difficult at first, obviously, because although the information we were provided certainly showed us that it was the right thing to do, we're busy, and so there's a lot of right things to do. I think that the biggest thing was getting the information, knowing that we really needed to do it, and then there was an incredible byproduct out of this where suddenly, after a rather short period of time, the ER docs started to realize that they were part of it, and we frequently get the call from them now saying either, A, I'm too busy, would you mind coming down and doing it? Or I've got it placed, we've got the numbers, and this is what's going on. That was a real evolution that helped us a great deal.
My role for the sepsis project is to collect all the data for the sepsis patient that's coming in, whether they meet the criteria for early goal-directed therapy or not. What I do with that data, I analyze it to validate it, and then what I do is report it off to the multidisciplinary team. And what they do is look at this information, see what ways that we can improve processes and move forward.
The biggest change for us was drawing lactic acids, also using the iStat so we can get results quicker. We draw lactic acids more often and more frequently, almost like we do troponins with someone with chest pain.
As a manager, and actually as a nurse prior to becoming manager in the MICU, it's been very exciting to see how the nurses react to the process and how many patients have been impacted by the process.
Because of this, we can now place central lines rapidly. We can infuse fluids and reach our goals more rapidly and get antibiotics in the patient much faster than we used to before.
The role that we play is to help facilitate the administration of both fluids and anti-infectives to make our timeline and outcome goals. We've also been a part of protocol development so that we can match patients' varying weights and renal function to appropriate dosing so that we have appropriate therapy from the start.
The role of an RT in the sepsis project is to run the mixed venous in a timely fashion.
The fact that we are trying to promote it throughout the whole hospital. You know, we're the critical care assessment team and we're trying to get the folks out on the floors to start paying attention to these kind of signs and symptoms so that we can catch it early.
I think the biggest thing that has helped me as a nurse here in the unit is the patients that came in prior to our sepsis protocol. The patients came in with the same diagnosis as they do now with pneumonia or septic shock, and we were not as aware as we are now, and they didn't do very well. Now that we have these protocols in establishment here, we're able to help them faster, quicker, and a lot of our patients now are able to go home. They go back to a normal life. We're able to grab it quicker and help them faster as we were not able to do before.
A 57-year-old man was brought to the emergency department after a 911 call to his house. His daughter reported that he had rapidly become confused and lethargic. In the emergency department, the nurse recognized that he had clinical signs of sepsis, so she performed a sepsis screen. She prompted the physician to order a serum lactic acid level. The lactate was 5. His source of infection wasn't yet clear, but here's what happened rapidly. Stat broad-spectrum antibiotics were ordered and administered in less than 1 hour from the patient's sign-in time. A triple lumen catheter was promptly placed by the emergency physician, who also notified the critical care physician. A 3-liter saline bolus was delivered to combat the progressive hypotension. Our early goal-directed therapy protocol was initiated, and all 3 targets were met within 50 minutes. The patient required intubation and mechanical ventilation for his deteriorating neurological and pulmonary status. A lumbar puncture done in the emergency department revealed the presence of turbid cerebrospinal fluid. This patient had septic shock and multi-organ dysfunction from pneumococcal bacteremia and meningitis. He was treated with the key Surviving Sepsis Campaign's recommendations within the first hour of his arrival into the emergency department. He was admitted to the intensive care unit, improved, and was able to extubate 5 days later. He made a full recovery.
Well, the day before, there wasn't anything special. It was Saturday, and I went to the restaurant with my daughter. I didn't feel anything. So the next day in the afternoon, I was watching a movie with my daughter. And that's when I started to feel sick, very sick. And then she went upstairs, and I remained there, and I felt very, very tired, like flu symptoms like. And I could not stand up, so I called her on her cell. She did not reply. I don't know, maybe she was taking a shower or something. And then I don't remember anything after that. So obviously, the next morning, she came into my room. She talked to me. I was confused, she told me that because I don't remember that. And then she called my wife, she was overseas, and she asked her what to do. My wife told her to call 911. And obviously, my daughter called 911, and they took me to the hospital. Obviously, I was tired, I was very tired. I had headache, very severe headache on the back of my head. But, the friends and my wife started telling me what happened to me, especially my daughter. She was with me all the time, almost. She told me that you passed out, you were confused, that we took her to the hospital. I remember that they called my brother. He lives in Las Vegas, and he flew here because my wife asked him to fly because my daughter was alone here, to help her because she was alone. So the first thing I remember that my friend, his wife, and my brother were standing in front of me, and that's the first thing I remember. I opened my eyes. I wasn't in pain, but I saw them. I smiled, and then I think I passed out for a couple of hours after that, and then I woke up again. And my wife was there, and she told me you have meningitis, and she wanted to make sure that I can hear her, or I can see her, or make sure that. And then maybe an hour or two, he came to the room, and he told me you have very severe case of meningitis. And he told me about the spinal tap and what happened. I was surprised, I was listening. Oh, I feel very good. I'm very thankful to the job you did. I'm really, I really appreciate what happened. I was in very good hands, and I feel great. I'm back to normal. I'm working in my backyard, and I'm fine.
So here we are 4 years later. Our sepsis awareness is much higher, our attention to detail much greater, and our sense of urgency more reliable and focused. We are a regional, private, non-teaching community hospital. If we can do this, you can do this.